This teleconference is made possible by a grant from the National Endowment for the Humanities. Welcome to this special Choices and Challenges Forum. The Choices and Challenges series at Virginia Tech explores the human questions, the ethical, social, legal, and political concerns that result from advances in science, medicine, and technology. Over the last 10 years, we have considered topics ranging from breakthroughs in genetics that can change the features of a single microscopic cell to advances in physics and engineering that can alter the way we function in our universe. Today's program examines the extraordinary advances that are changing medical care during that last and most burdensome illness, advances that have caused people to think about their own quality of life and what they might want if that quality of life slips away.
The quality of life is the general happiness that a person has with living, of which one component is good health, which means free of pain, free of fear.
Quality of life to me means being as independent as possible.
For me, it just means being able to continue having relationships with others in a fashion that's pleasurable to me.
Well, I think with the rising costs of everything, money is of great importance, and I think about it a lot.
If I am totally dependent and in no way if I'm able to get better, I think so, then in that case I would probably want not to live anymore.
I've had a full life. I've been fortunate. I don't want to go through a painful end. I don't want to be a problem to society or my family. I just hope that a truck hits me. I don't want to go to a hospital for months, and I hope eventually our society and our institutions will proclaim that sort of thing. The church has been preaching the beauty of heaven for centuries, but nobody wants to go there.
When my personal health wouldn't allow me to enjoy those things, to enjoy the people I was around or the activities I enjoy in life, then my quality of life would be diminished to the point that that living couldn't be a quality situation, and I think the quality would have to come from ending that situation, probably.
I think that it's not, right now, people have not clearly thought out what should be included or what they mean when they say physician-assisted suicide, and I think there are a lot of ramifications there. But the bottom line is that it does place too much power in the hands of a physician, and I think that there are many other alternatives for a person.
Personally, I like what hospice does. To me, I would want to be at home with the people that I cared about and who I knew cared about and loved me. I would want support for them. I would want a holistic approach that I could be able to deal with not only my physical symptoms, but my emotional, my spiritual, and my economic and social situation.
The big spiritual issue for me, or theological issue, is our fear of death. I mean, we treat death as though it's always an enemy, and it strikes me that there are plenty of circumstances in which it's no longer an enemy, but even a friend. And that if people, the fundamental issue for people is to how do they regard death, and what kind of comfort do they have in facing their death. Once we come to terms with that, then I think then it's less of a problem from any kind of theological or moral point of view to acknowledge that sometimes death is to be welcomed.
And now the moderator of today's program, a partner in the law firm of Buck, Levitt, and Beardsley, and former general counsel for the FDA, Nancy Buck.
Good afternoon. Good morning to those of you to the west of us. The better health care gets, the more choices we have. But the more choices we have, the more choices we have to make, and the more challenges we face for ourselves as individuals, for ourselves as members of families, for and with our family members, and as citizens of a society which is considering as never before how best to deal with healthcare choices. Today's forum is designed to help us identify and think through some issues that are certain to affect the lives and the deaths of all of us. Let me first introduce our panelists, and then I'll talk a little bit about how we're going to do this. To my left is Charles Sabatino, who is a lawyer. He's the Assistant Director of the American Bar Association's Commission on Legal Problems of the Elderly, and he's responsible there for research, for project development, and for education in areas such as health law, long-term care, and legal services for the elderly. Next is Javi Moraim, a philosopher who is concerned with economic issues in health care. She teaches and does research in the Department of Human Values and Ethics at the University of Tennessee College of Medicine. Howard Brody is both a philosopher and a physician. He specializes in family practice and combines the medical and the ethical in his own writings, and is director of the Center for Ethics and Humanities in the Life Sciences at Michigan State University. Michael Garland brings a variety of experiences in biomedical ethics and healthcare policy to this panel. He is professor of community medicine and medical ethics at the Oregon Health Sciences University, and he's also associate director of their Center for Ethics in Healthcare and co-founder of Oregon Health Decisions, a group that fosters public participation in health policy decisions. Therese Lysott provides us with the faith and religious perspectives. She is associate for religion, culture, and healthcare ethics at the Park Ridge Center for the Study of Health, Faith, and Ethics in Chicago. Now, just a few words about how this is organized. I think it's organized. First, we're going to show two separate vignettes about situations that can arise at the end of life. And after each of the vignettes, we'll show our audience, first we'll show everybody the vignette, the audience here, and also at downlink, they tell me the word is. And after each of the vignettes, the panelists will exchange ideas, views, and questions about the issues that crop up in the vignettes. Then we'll take questions from our audience, both here at Virginia Tech and throughout the country who are watching on television. You can get your questions to us by phone, by fax, or internet. I don't deal with internet, you computer people will have to figure that out, but the phone number is 1-800-544-4930. The fax number is 703-231-9498. Seriously, the internet number will appear on the screen at some point. You can phone or fax or send your internet messages at any time. You don't have to wait till the time for audience participation. So whenever you're ready, send us your questions. We'll work in as many of the questions as we can as we go along. And then phone numbers for the phone, the fax, and the internet will appear on the screen. And for those of you here, you have to come up to the mic and we'll talk then. Let's go ahead and start with the first vignette, and then we'll be back.
Oh, Andy, it means the world to me that you're here.
Well, I came as soon as I could. You've been on my mind. Are you in much pain, Elizabeth?
Not any more than usual, but I've got a big favor to ask of you, because he put
well,
that
I'm
thing...
your friend, and I'll...
Well, you better be.
I care.
I'm counting on you. This is probably cancer down here. They stuck this thing all the way down here and looked and did a biopsy, and he's going to come and tell me the results soon. And I don't think I need to even hear what he's going to say, but I've got to have some assurance. I can't go through this thing without knowing that I can stay in control. I need to be in control, Andy, and I need you to agree to keep a promise to me. Remember that promise we made each other? Do you remember about 10 years ago we had a long talk, and we both said, no, don't put me on any life support systems, no.
I remember that, yes, I do. We've had wonderful talks, Elizabeth.
And we were going to come to each other's rescue.
We didn't want to be in a hospital. We didn't be hooked up to anything against our will. We didn't want to be unconscious and unable to do anything.
We wanted to choose our time, and I'm calling that promise in.
Well, Elizabeth, you know I've been involved with hospice and helping people be at home and work with what can help them be comfortable and provide for you where you don't have to be in a hospital, and I'll do everything I can to help you with that.
You're not going back on your promise, are you? Andy.
Elizabeth, I've got to be honest with you. I
don't know who else to ask.
I know, but Elizabeth, it's not so simple, it's all that. Back then it seemed like this was an overdose and you took it, and it's not that easy.
I can't let them take control of my life and my body. I can't.
Well, Elizabeth, we can...
Please, Andy, please.
You'll be able to be at home Remember when you told me
Look,
about...
I'll find out what needs to be done, and you just get the stuff, okay?
Elizabeth, remember when you told me about your grandmother and how when she was dying, how much it really meant to the family to really learn about compassion and to really see your faith and action and how much it meant? And I really respect this whole journey you're on, and I'm your friend, and I'll be with you.
That's mean.
Hi, Elizabeth. How you feeling?
Well, I'm waiting to hear what you have to say.
I came by the nurse's station, and they said that you've gained about 5 pounds in the last couple of days. So your alimentation is beefing you up a little bit.
Oh, this is Andy Sisson, an old friend of mine. He's
Andy, how are you?
Yeah.
hang around here and sit by my side and hold my hand. This is my Dr. Larry Cooley. He's really a fine doctor.
I've seen you around the hospital.
Yeah, you look familiar.
I work with the hospice program.
Good.
I've been a long-time friend of Elizabeth.
Hey, he's not here on hospice work. He's here for me.
Oh,
right?
I'm here for Elizabeth.
Right.
Glad you're here. I just talked to the pathologist, and the report is pretty much what we expected. It's a serious kind of tumor. It's called a squamous cell carcinoma.
Ugly word.
It's located in a bad place. It's right there where your swallowing tube goes into your stomach, and of course it explains all your symptoms of weight loss, loss of appetite, and all your belching you've been having. The x-ray yesterday afternoon shows that you've got some spread over to your liver as well. And right now surgery's not indicated, but I think some radiation therapy, maybe even some chemotherapy. I want to talk to the oncologist and see what might be recommended there.
What kind of time are we talking about?
Several months maybe, Elizabeth.
Several months.
They can be made very livable if you undergo a little palliative radiation treatment.
Months. Andy. Larry, I've been talking to Andy, and I really need help with something, and I've got to be real straightforward with you, because I feel like you might be the only person that could answer this question for me. Now, you know what a control freak I am.
Absolutely.
And,
I've known you a long time, Elizabeth.
The only person in the medical community I trust is you.
Thank you.
I don't trust this hospital. I don't trust the technicians, and I'm not about to put my body into the hands of strangers in these last months, you say? God, months? Larry,
it's a bad disease,
I know,
Elizabeth.
and what I'm asking you is I need help to finish things off when I'm ready. When I'm ready.
I promise you I'll give you pain medicine, all you need to make you comfortable.
No, if we were in Holland, we wouldn't have to talk like this.
Yeah,
you
they
could
do
just
things
say,
different there, Elizabeth.
make the date and I'll be there. I know they do them differently.
That's right.
You'd take your dog to the vet, wouldn't you?
Sure, my dog, but you're different, Elizabeth.
I'm different. Well, I hope I'd be more important. Aren't I your friend?
You're a friend, but you're also my patient. And I can give you
Help
my
me,
word.
Larry, for God's sakes, please, I'm not asking much of you.
Elizabeth, I'll help you. Andy and his group will help.
But that's not the kind of help I'm asking for. I'm asking for a commitment, a specific commitment.
You're asking me to do something that I can't do.
This vignette provides a little insight into how the patients react and maybe how the physicians react and how friends react. Rather than asking specific questions, let me get each of your reactions first to this vignette. What's the framework in which you consider it and think about it and talk about it? Therese?
I think, to begin with, it's a good vignette because it captures, I think, most people's first response, or the response they think they would have in that situation. It doesn't represent some of the more difficult questions, which I think would probably occur 5 months later,
right.
When she's at the end. But I think what it opens a door. It looks like an either-or situation, but I think it opens a door for the physician and her friend and Elizabeth to, over the subsequent weeks and months, to not necessarily simply refuse the request for assistance, but try to explore what she's really getting at in that request. Clearly, she articulated she's afraid of losing control of her body and being taken over by a hospital and technicians. And that's a valid fear. And clearly there's fear of pain, of debility, of being isolated. And I think with her physician and through hospice, those kinds of fears can be dealt with on a day-to-day basis as they come up. The fears will change over the course of her illness, but by providing practical responses to each one, it may forestall the need for the physician to honor her request.
Mike, what are the range of choices? Elizabeth's focused on two, suicide or not. What are some of the other choices?
Well, there certainly is a range of choice, and I'm going to sort of bump that over to Howard, because the earlier question you asked was how do you react to this? And I have to say my first reaction is this is a very nice focusing glass that allows us to look at a single issue involving a couple of people, and that has some general features to it. The solidarity, the friendship, and the fear, and the request for help are very important features of the single individual case, and how this woman is going to solve it is all dependent on how those aspects of it play out, how her physician stands by her, how her friend deals with her or finds other friends. But I'm always much more concerned with what is required at a social level for us to be able to deal not with Elizabeth, but Elizabeth and all the others who are somewhat like her. Elizabeth and all the others who have requests and feelings like her. And my concern is how we can not just deal with the single friend standing by Elizabeth, but with all of us being friends or a community of solidarity with those among us who have those kinds of fears and literally are asking for physicians or somebody to help them put it to an end, call their life quits when they want to. And so it moves it up to another systems level, which is the level of community and public choice and public policy.
Howard?
Therese did a wonderful job, I think, of laying out some of the issues that a clinician would start with in trying to figure out how to try to help Elizabeth. Elizabeth strikes me in this vignette as being very scared. And in order to help her, we're going to have to do a couple of things. I think for now, we're going to have to try to offer some reassurance, which is coupled with a promise that we're going to come back and talk to her later, when things have had a chance to settle down, given that no decision, whether it's a decision to go on chemotherapy or a decision to die, really can adequately be made at this time of crisis when you've just heard the diagnosis. And I don't believe that the fact that she anticipated it was going to be cancer has necessarily lessened the emotional trauma of actually hearing the verdict, if you will. Now, if she's scared, then as Therese pointed out, we don't know exactly what she's scared of. We know she's scared of loss of control, but what does that mean? Does that mean that she wants to die now because she can't even face tomorrow, waking up and knowing she has an untreatable cancer? Or does it mean that down the road she's afraid of something like being dependent on machines, being in pain, etc.? So we really have to find out what the content of that fear is. Now then we get to the fork in the road, where some physicians would want to go as to say that in order to give Elizabeth the reassurance that I know she wants, I would have to be able as her physician to promise, yes, I will help you die in the end if nothing else works. If we have tried all other medical means to relieve your suffering, and if you continue to be competent and to voluntarily request this, in the end, as part of my promise of non-abandonment, I must go that last step of the way with you and help you die. Other physicians would say, absolutely not, that would be a total violation of my healing commitment that I have as a health professional. In either case, there's so much we could do before we would get to that last point that we need to know the content of her fears, and then I think we can organize a number of other possibilities for her. Now, she might reject those, and she might say, no, that's not what I want. I don't want hospice. I don't want spiritual and emotional support, and so on. But as physicians who must heal, and some would say we can only heal, we can never kill. Others would say maybe we should be allowed to kill in rare cases, but only after healing has failed, after we've tried it. In either event, we would have to go the route with her and try all these other alternatives. And sensitivity to what is bothering Elizabeth would dictate what those other alternatives might be.
Tommy?
Yeah, I find this vignette to be a very poignant and a moving vignette for a number of reasons. She pays a lot of attention to this control issue, and that's very important. And I found myself thinking about, all right, what do we mean control? What is the importance of control here? And ultimately, even though sort of on a superficial level we think in a negative way about control, we say, oh, so-and-so is just a controlling person. What is control? Control is linked very intimately with human autonomy, which is linked with dignity. When people talk about death with dignity, a lot of times what they're talking about is death in control versus completely out of control. So what is she worried about when she talks about not wanting to lose control? Well, for one thing, there are lots of cases where people do completely lose control when they go into a hospital, even for little things. Anybody who's ever been in a hospital knows that you can't eat until they bring your food to you. You can't, in many cases, do what, answer nature's beck and call until somebody comes after you ring a buzzer, and maybe nobody will come. You lose control a lot in a hospital. We all know that. And also, there are many physicians who are not willing to relinquish control to a patient, perhaps especially in the context of dying. Many physicians consider it to be a personal failure when a patient dies, and they want to stave off failure. In some cases, a physician may have the idea that it's unethical to do anything less than everything for a patient who is going to die. Somehow they've got this idea that medical ethics says you have to preserve life as long as possible. That is incorrect. Medical ethics have never said that you're supposed to somehow keep the patient suffering as long as possible, as long as he can be alive. Ethics has never said that of physicians, but some people feel it does. Some doctors are very reluctant to feel like they're the cause of death. That's why some physicians are reluctant to give really adequate pain control. The National Institutes of Health recently has come out with some studies on our medical use of pain control in this country, and one word that was used in the context of this study was virtually barbaric in the inadequacy of pain control that we give. And one of the reasons is that some physicians, and I'll also add in here nurses and some other health care providers, are very afraid of giving adequate pain control, really adequate pain control, because number one, they're afraid that they'll depress respiration and maybe, quote, quote, kill the patient by hastening death. They're afraid that they might get the patient addicted. Why on earth somebody would worry about addiction in a patient who is dying, I can't imagine, but people do actually worry about addiction sometimes. Some physicians are afraid that the law will jump on them if they relinquish control to the patient and let the patient die at the patient's in the patient's time, even by letting go of life support, even withholding or withdrawing life support. Some physicians think that they're going to go to jail if they do that. They're wrong. There are many, not only court case precedents, but also statutes that protect physicians who are willing to relinquish life support, at least under certain kinds of circumstances. But bottom line is here that this lady is concerned about completely losing control, and she has some reason to be concerned. This is not baseless fear. But here's another element. She does trust her doctor. All right, she knows that Larry really does have his heart with hers and wants to make sure that she does not suffer. But Larry is not the only one in the picture. There's this whole hospital network, all right? And it's one thing if Larry writes the order for pain control whenever the patient needs it. It's another thing if the hospital has hired enough nurses so that they'll be free to go and give the pain control when she needs it. So she has some very real concerns here, and they are not to be somehow cast aside as though they are irrelevant. At which point then we come back to some of the questions that have been asked before. How do we give the patient assurances that are real, that she can trust? Right now, she has a lot of mistrust. How can we construct a situation in which this patient really can trust when her doctor, Larry, says, I will make sure that you have pain control, that she really knows that it's true and that she will get pain control, or whatever the kind of relief she may need?
Well, I approach this from a legal framework, and my initial reaction to this kind of powerful vignette is that the law is very unhelpful in a situation like this. And in the clinical setting, we make a mistake if we turn too quickly to what the law says or doesn't say, including, I think, making any pronouncements about what I will or will not do as the physician, because that's against the law. That's really the wrong kind of limit setting to be throwing into the situation at this time. But But having said that, and appreciating the limits of the law, I mean, there is a framework that the law creates, and there's at least 3 aspects that I think have to be kept in mind in this kind of scenario, which involves a patient requesting aid in dying. Number 1, suicide is no longer illegal in virtually every state. That's not to say that it is a right, but it is no longer illegal. On the other hand, assisting suicide is illegal in the majority of states. Point number 2 is that the right to die, as it is called, and I think that is a misnomer, but that's what it is commonly called in this in our society, is really better described as a right to refuse unwanted medical treatment. It is based upon long-standing common law notions protecting one against unwanted bodily intrusion, unwanted touching. That's what the whole tort of battery stands on. There's also recognition in the common law of the right to self-determination. And these rights have led to notions of informed consent, and they've led to the notion and the right to refuse unwanted treatment. And there also is a constitutional component to this, but it is basically a right to be left alone. There's a useful distinction, I think, in ethics relating to autonomy between negative autonomy and positive autonomy. And individual rights in Western law have basically been based upon the notion of negative autonomy, which is a right to be left alone. Positive autonomy and positive rights are really a right to affirmative assistance in reaching some goal that you want, in this case, aid in dying. And that is not an approach to rights that is generally embraced in our system of law. For example, there's really no right to minimally adequate health care in this country, nor a right to housing, nor a right to an adequate income. These are rights that have been created by statute, and they can be limited by statute. Now, of course, once you grant those rights by statute, there are constitutional components relating to due process and to fairness. You can't not take those rights away unfairly or treat different groups unequally. But the underlying right to them is something that is created by statute. It is not inherent in neither the common law or constitutional law. So this right to die has to be, the history of it and the foundation of it has to be looked at in that sense. And finally, the law makes a distinction and has made a distinction in this whole development of letting one die versus killing them. Now, we could have an extended discussion about some of the problems with that distinction because there is fuzziness to it. There are some problems to it. But in the development of right to refuse treatment law, it has been a pretty secure footing that has prevented those who argue the slippery slope argument, has prevented those from prevailing in the slippery slope argument. It has been a firm plateau on what has sometimes perceived as a slippery slope. And physician aid in dying is an action that would break through that particular stop that we have relied on so far. So those are 3, I think, important aspects that apply to the framework of the law here.
I'd like to push at least 3 of you a little further. Elizabeth was very clear in what she wanted. She said she wanted help in dying. She wanted help in committing suicide. And I think by my count, at least 3 and maybe 4 of you, I'm not sure, essentially said, well, yeah, but what we have to do is help her see that she's got other choices. You know, tomorrow she'll, Scarlett O'Hara version of this, tomorrow's another day. I want to come back to this and push a little bit, Howard, on why you don't have some obligation to grapple directly with what she said, if not today, tomorrow. Because otherwise we're just traversing further and further away and saying, well, we'll see about that, Elizabeth. Let's try this, let's try that.
Nancy, let's add to that. Not only Howard having to deal with that, but all of us having to deal with that. What promises are we going to let Howard give?
Why don't we believe Elizabeth now is where I kind of want to start. She was quite clear.
Yeah, again, I think what I tried to say before was that it makes a difference what I'm willing to promise Elizabeth now in order to carry on the conversation. Okay. Now, Larry in the vignette has basically said, Elizabeth, I can't do that, period.
Right, forget it.
But let's talk.
Mm-hmm.
I said a minute ago, I would personally favor an ethical stance of the medical profession that says, Elizabeth, under certain circumstances, in the end, I can promise you I will do what you ask me. But before we get to that point, or in order to know we've got to that point, you and I have to talk a lot more. Now, there's an ethical value of that, which we can talk about. There's a clinical value. The clinical value is that if you promise patients up front that you will be there in the end to help them die, a significant number of those patients turn out to die a natural death without suicide because they've been given the confidence and hope necessary to face the natural progress of illness. So you've accomplished a lot just by being able to make that promise, I believe.
I think those are tactics in avoiding Elizabeth's question. I want somebody to tell me why you don't have to grapple with what she said absolutely clearly she wanted. Javi?
Okay, yeah. It seems to me we've got not just one person, we have two people who have dignity, autonomy, and yes, some measure of control. If a physician says, I cannot in good conscience do this, this would violate me, my integrity as a person or as a professional for whatever reason. The fact that a patient wants something does not mean that he or she should be free to coerce a physician to do whatever that patient wants, regardless of the physician's position on that. Okay. And that's important. So a physician may feel obligated to make sure that a patient does not, I mean, even if he's willing ultimately, as per Howard's proposal, even if a physician is willing ultimately, yes, I will see to it that you have these means, it may be also part of that physician's personal, professional autonomy to say, look, I'm not going to do it shy of doing certain other kinds of things.
Right, but you're doing what the doctors do. You're not, the doctors aren't the ones who are dying here. What I want to know is, why doesn't Elizabeth have the right to have somebody deal squarely with the question she raised?
Maybe her feelings will be different tomorrow, or 2 weeks from now, or 3 weeks from now. What if we act?
It will be, so you don't have to get to the suicide.
Well, if you want to respect the physician's autonomy, this is a complex. To just focus on the patient is to abstract one piece from a very complex system. I think too, if we look at illness narratives, stories written by people who have either gone through cancers, something really difficult, or journals kept by individuals who have subsequently died. Most people who write those are kind of like Elizabeth or me, you know, work freaks or control freaks, and they run into illness, and it's the end of their identity in a way. They lose their work context, they lose their social relationships, they lose their physical function. But time and again, if those losses are managed well, they find that they discover a new self, a new distilled self. So whereas today, the thought of losing the ability to work would seem to me to be the end of my existence as I know it, there might be a value that I would discover if someone would walk with me that extra week or month.
Nancy, you put the question as, why shouldn't she have that right? And that raises it a very big notch. It raises it to a policy issue that has to look at more than just Elizabeth. The situation may progress with Elizabeth in which all of us here might agree that for her case, maybe that is a morally justified thing to do in the case of Elizabeth. That doesn't automatically mean that as a public policy, in our system of law, we should automatically change that, because many more factors play into it, at that point. Any policy that is established, including the ban against assisted suicide, no policy benefits 100% of the people. No policy avoids harm to 100% of the people. There's a much more complicated and complex weighing process that we have to go through.
I think those are fair points, but what I was trying to get at is to see if I could distinguish between the temporal. Tomorrow we'll talk squarely about suicide. Both Elizabeth and the physician are entitled to a day or two to get through the process. And my sense that many of you at least want to slide off this and hope that we can hold carrots in front of Elizabeth that says, Elizabeth, pain management, therefore no suicide. We'll help you with control, therefore no suicide. And if we can keep it up long enough, we'll never get to suicide before she dies. That's my question.
Elizabeth, do you want to know the bottom line, Elizabeth?
Yeah.
There's two circumstances under which I feel as a physician of integrity and conscience that I could go along with your request. Condition number one, I know that this is a voluntary, thought-out choice that you exercise over a period of time. So I know it's not just what you say today, but that over some time you consistently say this is what you want. Point number two, other healing opportunities that we in medicine can offer you turn out not to work or turn out for whatever reason to be unacceptable to you because of your values. Because I'm primarily a healer, and that's my professional identity, I don't feel as a person of conscience I can offer you assistance with dying unless those two conditions are met.
Okay.
So that's what we have to work with.
It's also an issue of informed consent, in a way. If she is making this request based on a fear, or at least that's what the physician's presumption is, then it's not fully informed. She's afraid something might happen. She's afraid she might get into a particular condition, and she might not get there. So time will give her information.
Yeah, and Howard and the informed consent and the kind of delaying tactic, because you don't want to move cautiously into this, is a mirror of all of us. For me, the shortest answer to why she doesn't have the right is that we have not given her the right, and we, the people of this state, of this country, of this nation, are very ambivalent in our hearts about this. A lot of us believe that suicide is absolutely wrong, so there are no circumstances that would justify it. A lot of us believe that assisting suicide is wrong, especially for physicians, because it corrupts their professional relationship. And in the midst of us, among us, there are people who believe that neither of those are absolutely wrong, but they are things to be done with great caution. So you look carefully, as Howard has done, putting two non-negotiable conditions in front of a patient, to look carefully at the conditions under which we would say, yes, Elizabeth, you have a right to call on me, and I am one of those in this profession who is willing to go this far with you on the road that you're choosing to go, and here are the conditions that I will be able to do it. And I can do it out loud, publicly, not in secrecy, only if there is enough of a social compact, either through the passage of laws or the kind of funny dance they've done in Holland of saying, well, it's against the law, but if you follow certain conditions, we'll let this go. So I think the finger, as usual, points all the way around the circle and has to include all of us.
But I'm just going to say that it seems to me there are two very different scenarios that could accompany this particular vignette. One is the kind you're talking about, and it's very real. This kind of conversation saying, look, we'll talk about pain management, as basically a tool of manipulation. Just keep putting it off until finally you win. The patient dies completely out of control. Just her worst fears now materialized. That is one scenario, and it's very real, and it does happen. However, another scenario is the kind that I think Larry may be undertaking in good faith, and that Howard is proposing, I think, also very much in good faith, and that is doing some screening here. Because there are many cases described in the literature where somebody who says, I want to die, it turns out that isn't what the person wants at all. And a good physician has got to screen those out. And this is not only for the purpose of making sure that the patient understands things. This is an exercise that I think is absolutely crucial to make sure that physicians continue to communicate. This is as much to make sure that physicians stay where they belong, as much as to ensure that patients are not being mishandled or somehow important things being missed.
Could I just add, I want to, again, as Javi has done, distinguish between a manipulative use of the let's delay things versus the therapeutic use. I'm reminded of a patient's story that appeared on a Frontline documentary early last year. It was, I believe, about euthanasia in the Netherlands, where a patient described how he was given the assurance he needed from his doctor that if it ever got too bad, he would be killed. And the patient mentioned, by the way, now it's 4 years since my diagnosis of cancer. When they diagnosed me, they gave me 6 months. I believe that it was the confidence and the security, the ability to relax and not fear the future, that made the difference between my living the 4 years that I've now lived in good quality as opposed to dying in 6 months like they thought I was going to.
I think, too, though, the promise at this point, or at a point this early, can also be a kind of abandonment, because it doesn't address the causes of this significant movement toward assisted suicide in this country. Causes like bad physician-patient communication, physicians' inability to deal with death, bad pain management. And so in some ways it might be easier for a physician to say, okay, fine. And then you don't have to talk to the patient. So it could be manipulative or abandoned. It depends on the interpersonal dynamic.
Yeah, I would really second that, because agreeing that aid in dying assisted suicide ought to be lawful doesn't make this situation a lot easier clinically or realistically. And I wanted to comment on Howard's conditions that you laid down. Let's turn this to a policy issue now. Could those translate into good public policy as a way to permit assisted suicide? Well, that worries me a lot, particularly the knowing involuntary nature of it. In the right to refuse treatment legislation so far in this country, we've already gone way beyond limiting it to competent patients knowingly and voluntarily refusing treatment. We've already gone beyond that to allow this right to continue to exist in a fashion in incompetent patients through a legally authorized surrogate, either an agent under a power of attorney or a family member under a family consent statute, who make a decision based upon the notion of substitutive judgment, of standing in the patient's shoes and trying to decide as they would. We've gone so far with that area, in that respect, with end-of-life decision-making. I really worry about how we could contain it in a public policy that permitted assisted suicide.
We've got questions starting to come in, and let me just encourage the audience here and there to continue to send us some questions while we continue to kind of wrap up our end of it. Mike?
I just wanted to say that is the very heart of public policy, is dealing with those worries. And the fact that we worry about them is a good sign, and I think shouldn't stop us from moving forward and facing them as public issues, using means by which we can sit down face to face and really sort through our values and figure out what are the things that we really want to have in place, what are the checks and balances we really want if we're going to move forward in this. And I think that it's, instead of a reason not to move forward in public policy, it's exactly the reason to move forward in public policy, to get those issues out on the table, those worries and concerns on the table, so that we can find out if there is a way to build fences on this famous slippery slope.
I'd like to ask a question along the following lines. One of the things that I'm beginning to recognize or sense as I listen to all of you is that the medical profession, ethicists, philosophers, lawyers have all done a great deal of thinking about these issues over the last 5-10 years. And in some sense, some consensuses have developed, because you can hear it here. The five of you don't all agree about everything, but there's a method or a procedure. What that means, it seems to me, is a kind of peculiar power imbalance between the patient and the entire establishment. The patient is dying for the first time. And the physicians, of course, and the ethicists and the philosophers, the clergy, the lawyers, have all been thinking about this and thinking about this. If you were a patient, think about it from the standpoint of Elizabeth thought she was prepared. She and Andy had a deal. Andy Welsh is on the deal. And there she is. What should a person who's even thinking about these kinds of issues as an individual for himself or herself do to prepare so that there's not such a power imbalance at the moment you need to be prepared? How do you think about getting yourself prepared to talk to your doctor, to talk to the others who are around you, so that your autonomy is real?
Well, it's not necessarily a power imbalance. It could be described as an experience imbalance. Okay. And you know, in many areas of life, we learn from others who have more experience dealing with whatever than we do, and then we expect them and trust them and hope that they will say, here's a bunch of cases that are analogous to yours, kind of, and they will help facilitate the patient's autonomy. This is the first time you're here. These are some things that you might anticipate. These are some things you might be feeling, and help move the patient to a place where the patient wants to be, not in a manipulative way, but to empower them, to transfer some of that power.
Go ahead.
Add to that.
Sure.
One of the things that I think is helpful here, although it doesn't totally change Elizabeth's situation, is the stress that has been placed recently on advanced directives, or so-called living will, durable power of attorney for health care. The whole idea of thinking in advance about what is quality of life for me as I face the end of life, and then how do I put that on paper or communicate about that with my family and my physician, and generally plan ahead, is, I think, most patients and families find that a very empowering sort of experience. So that at least gives you some leg up. And then if you talk to your doctor at that point, what if Elizabeth had talked to Larry some years ago about this and said, Larry, if I ever ask you for assistance in suicide because I feel that's the only way I can enjoy the quality of life I want at the end of life. And Larry says, personally, I could never do that. Then that conflict is out in the open. It can be talked about, and perhaps Elizabeth needs to find another physician. Perhaps Larry can persuade Elizabeth that's not necessary. But it has come before the crisis. And so I think there's a lot to be said about this kind of what now people are calling advanced care planning as a process of communication between patient, physician, and family.
We have a question along these lines, so let me read it, and perhaps those of you who are about to comment on Howard's point can kind of fold in your answers to this. The question is about the specific roles of the patient, the family, the physician, and their responsibilities in the last stages, 3 to 4 weeks, in terms of the rights of the patient to determine what the quality and the quantity of the support systems is, not quite suicide, but close to it. A kind of a patient bill of rights in this area. That's what you were about to say in terms of preparing yourself with your family. Javi?
Well, yeah, because I am in the field of medical ethics, I find periodically people will just, in conversation ask me, well, what can I do to make sure that I don't die like so-and-so that's in the news, hooked up to all those tubes? And one of the most important things, well, there are several, but one of the most important things is to talk with one's family or with whomever it is that you tell your heart and soul to. As a matter of fact, I personally have made it a real point to talk with my own parents. They are healthy, active, vigorous, wonderful, thoughtful people, and now's the time to be talking about this kind of thing. Saying, all right, how did you feel about this case or that case? And my mother has had certain friends of hers who have gone through some medical mayhem, if you will, at least in her estimation. So we talk about these cases. And I remember one time, actually, I was giving a talk to an audience, and I found myself saying, well, I know of a gentleman who feels this way, and I was sort of, in my mind, as I offered this, I was trying to capture what I thought my dad would feel. And then afterwards I thought, well, it's all very well for me to speculate like this, but, let's go straight to the horse's mouth and ask Dad, do you feel this way? And he said, absolutely. And so it's important so it's important to talk with your family and also then talk with your physician and say, hey, look, just as Howard was proposing, talk with your physician. Again, don't wait till the last minute until all you-know-what is breaking loose, because it's very hard to take seriously the request of somebody who is under extreme circumstances, just learned she has cancer, as in the case of Elizabeth, or somebody who is in great pain, whatever it may be. Think about it ahead of time and then periodically reconfirm. And then when you finally are in sort of the dying mode, it's also important to talk with other caretakers. For example, if you're at home, you've got to tell the nurses who are caring for you at home, don't call 911. Or you've got to have a portable DNR, do not resuscitate, DNR, which means that if somebody does take you to the emergency room, you are not all of a sudden going to wind up on a respirator, because when somebody comes rolling into the emergency room gasping for air, they have one and only one thing that they can do, unless they know for sure not to do it, and that is to do whatever is required to keep you alive until they can find out more.
Let me add to that we don't do a very good job at educating people to do this advanced planning. If I had the ability to take a poll of the audience, I would bet you that the response rate to the question, how many of you have an advance directive, would be pretty close to what the general population seems to be, about 20% at the most. We tend to wait until the emergency comes, and we don't have in our society ways that are easily presented to us to structure these conversations, and conversations is what they need to be.
Religious communities are a kind of grassroots public policy resource that could facilitate these conversations in a kind of preventative way, because religious communities are the places that have traditionally mapped out these meaning questions, the meaning of suffering and illness and dying and death and salvation and caring for others and being dependent. And they could facilitate these conversations within communities of shared values, and then facilitate concrete, constructive ways of caring for the sick and the dying locally.
I expect we're going to question of how people can plan. I want to try and see if we can get one of these telephone questions. We have one ready, so let's go with the telephone question, see how that works.
The question is, should some organization other than medicine or hospice be responsible for assisted suicide? And the second question is, the patient stated to her doctor, quotes, "I'm not
Boom. Yeah. Beware in the front rows. First with footnotes. A lot of our conversation, you know, so much has to do with how we frame our issues and our problems. We put them in some kind of box and we say, this is the box. And a lot of this keeps focusing on a frame in which we see an individual, we call that individual a patient all the time instead of a person, and that person is having some dealing with probably a physician. And it's those dyads that we keep imagining and try to solve that dyadic problem. Whereas what Therese raises is a community perspective, a community of believers who are used to, and in that environment frequently talk about ultimate things and what is of greatest importance to them. That's one of the community environments in which we really need to perceive this as going on. The other one, which we reflect backwards on, is the family. That all of these people whom we keep seeing as patients are members of families first, and very frequently they're first of all living there and having an important working out of human meaning in that family. So a lot of this work has to do with putting it in that frame where we see ourselves as members of important communities. Hence, I keep raising the issue of dealing with this as law and as public policy, because that's an important community that makes a difference on which of the promises Howard is willing to make, he can make publicly and openly.
Some of you talking about getting with your family or community, whatever community or communities I think you're a part of. One of the questioners has asked, how certain is it that individual choices, even if they're voiced and put into print, will really be honored? And makes the analogy to organ transplantation, organ donation, where physicians and hospitals will not ordinarily honor a decision to donate organs if that's the patient's choice, unless the family is willing to go along. Is this the same kind of thing? How does forget the suicide for a moment, which raises different sets of questions. Assuming that the patient's choices are essentially legal, how do you get them effectuated?
We just recently had some data on this. Somebody actually did a study of people going to a bioethics conference and gave them a case scenario and said, how would your bioethics committee or how would you decide this case? And it turned out that when you just let the case be a straightforward case, there was pretty good agreement. And then you got into increasing disagreement, and the single factor that I recall that was a predictor of that greater disagreement was what about when the family among themselves disagreed about what should be done. So if you wanted to, now I'd like to say that don't worry about it, because all doctors are so well educated in legal and ethical concepts that they will know that the bottom line is what you want and not what your family says. So if they have in writing and they have in confidence from their previous conversations with you what you want, that will be done, and don't have any concerns about it. I wish I could say that. I can't say that because we haven't got there yet. We still have a lot of ignorance and a lot of fear in the medical profession that bad things will happen, as Javi mentioned earlier, if they go against what the family says, even though they know that may be in conflict with the patient's wishes. So where we have, just quickly, it's back to communication again. If you communicate with your family, and the family who's likely to be there at your bedside in a crisis knows well in advance what your wishes are, and you've talked this out with them in advance, then the likelihood is greatest that your wishes will in fact be followed.
Charlie, I hope you're going to comment on what happens when you never got along with your family and you're not doing any better now and you still want your wishes.
Well, this problem is one of the reasons why the advanced directive law in this country evolved from what's called living wills, simple statements of instructions, to putting a greater emphasis on delegating an agent under healthcare power of attorney, which is so crucial to do, precisely because I have never seen a piece of paper that isn't subject to interpretation when you spell out wishes or instructions. And if that's all you have, then dissent among close family members does make you uncomfortable. But if you have a clearly authorized person, and most of these statutes also, by the way, you give the physician immunity for complying in good faith. If you have that decision maker clearly authorized, then you're much less likely to have this problem of dissent in family undermining what's going on.
Let's back up for a second. What's the general range of what advanced directives allow you to do? We are all assuming. I'm not so sure I really know what they are, even though I can use the words. What are they?
I'll be glad to jump in again. And this does vary from state to state. The original advanced directive laws really were confined to terminal illness and eventually to a permanent coma. But most healthcare power of attorney statutes really empower the agent to make decisions to consent to or refuse any suggested healthcare intervention that may come down the pike. And those states that haven't gone that far, I think, are slowly going that far. Now that does raise the question, what if the agent says, I want to refuse something that is life-sustaining and the person is otherwise in pretty good shape? It's not going to solve that problem. I think physicians are still going to act to try to protect what they see as the best interest of the individual. But the breadth of advanced directives has been moving in a direction of greater broadness as to what they cover.
Let's go back to the suicide. Mike?
Not suicide, not assisted suicide, and not lethal injections. That's not in any of them.
Right. Yet. Are there other countries where assisted suicide is permitted? Squarely permitted. Does anybody
know the exact on Germany? I've read articles on Germany that describe that while Germany is very strongly, as a society, opposed to anything that looks like euthanasia, and a philosopher who went to give lectures about euthanasia in Germany a few years ago was basically forced to be quiet and leave the country because nobody would let him talk. Nonetheless, there's a sort of voluntary association in Germany that promotes a right to assisted suicide, and they've developed some kind of a form which, if the police go into a scene of a suicide and they find this particular piece of paper, which is a distinctively colored piece of paper, filled out and signed next to the dead body, they basically have an agreement that we will not prosecute this, everything's going to be okay. And so there has become at least sort of a quasi-legal acceptance of suicide assistance and providing the means to commit suicide in Germany, according to at least one article. Then, of course, we have the Netherlands, which we've discussed, where we have it's sort of illegal, sort of legal. But that's more euthanasia, and only a few of the cases in the Netherlands are assisted suicide.
Yes, it's also important to distinguish between expressly permitting something and not forbidding it. Up until really, quite recently, actually up until the Kevorkian era, if I may refer to the name. Up until then, basically, lots of states said nothing about assisting suicide. I mean, suicide is not against the law, and it's hard to picture how it can be against the law to help somebody to do something that's perfectly legal. And then we get the Kevorkian era, and a lot of people all of a sudden say, ooh, this is a little bit scary. We need to put some laws in place here. And actually, as we were talking about at lunch today, the Michigan law has this interesting feature that says, assisting suicide is a criminal offense for thus and such a period of time, essentially until we figure out whether it's wrong. While we study the issue and so forth. And that's an interesting response in itself, I think. So long as something is not forbidden by law, then in essence it is permitted. Now, what we have, however, alongside of that are homicide laws. And for all the reasons that Charlie was talking about, the problems of expressly permitting assisting suicide in a statute, it is very hard to draft a statute that will allow just the cases you want and not open the door to other kinds of cases that would constitute abuses. Reciprocally, when you have laws forbidding assisted suicide, you potentially really do handcuff a physician like Larry in our vignette. Larry says, I will give you all the pain medication you need. Frankly, if he gives that to her and knows that she's stocking up, then he may run a risk of criminal prosecution in a state that forbids assisting suicide, because some prosecutor might say, ooh, you knew that she was stocking up, you knew this could kill her, you assisted her suicide. So that any place actually a country does not forbid it may be a country that in some sense permits assisting suicide, but with the caveat that if somebody gets a little too vigorous about this, there are homicide laws to step in.
What do we know about who wants or says he or she wants to engage in assisted suicide? Is this a kind of an upper middle class intellectual preoccupation, or do people across all strata of society, all races, all genders, raise these questions when they're patients at the end?
One thing we do know, I don't know that we know as much as we'd like to about social class. We know in some attitude surveys that African American respondents are significantly less likely than white respondents to approve of euthanasia and assisted suicide. to the point where typically in most surveys, somewhere about 55 to 60% of the general public says this is a good idea in the U.S., where it may be only, say, 45% among black respondents. And when I talk to some people from that community, the comment that I hear over and over again is, we have so much reason to distrust this white-dominated medical establishment. We don't know that they would use such a tool to our interests. For all we know, they want to get rid of us to save money, or they want to get rid of, they may want to do experiments on us in the teaching hospital. We don't know what they might do to us, and we're not ready to have that kind of power in the hands of physicians who we don't have the same trust for as those who are in the majority. Now, the other group that has been very strong in opposing assisted suicide has been some representatives from the disability rights community, fearing that those who with disabilities would be the first to get labeled as having poor quality of life and therefore slated to be benignly killed. Whether they want to or not, there would be a subtle pressure placed on those folks to sort of get out of the way because of their use of resources.
We have just a few minutes in this segment, and it is alleged that there's a telephone call. So let's try it one more time.
The question is for Dr. Brody. And the question is kind of a three-stage question. Number one, why not deal with the quality of life at end of life in stages? Stage one being dealing with the fear situation. Stage two would be getting the patient to understand the body changes and the mental changes that are occurring. And stage three would be dealing with the medical problem or problems themselves.
I think trying with the patient who has a lot of fear, trying to get the patient to articulate clearly what they're afraid of and then breaking it down into manageable pieces is an excellent way to deal with that fear. So I think as you sat down with Elizabeth and tried to talk with her, that would be a good schema to use.
What's the physician's responsibility if the patient says she's going to do it herself? Are you then obligated to try to prevent the patient from doing it? Do you have her detained for a psychiatric evaluation, or are you allowed to just listen to that? Well, no, he doesn't have to answer.
Well, I'd be very curious to hear from my legal advisors what kind of trouble I might be in if I listen. I would like to think that I have a clinical responsibility to assess a patient who expresses a desire for suicide. We know statistically that about 95% of all the people who say in our country they are suicidal have a treatable psychiatric illness, and after getting psychiatric treatment, they no longer wish to die. And so that seems to suggest I have a very heavy clinical responsibility to try to distinguish the 95% from the 5% that I believe exists where people are making rational.
You've been treating Elizabeth for years here, and Elizabeth didn't.
Clinical judgment. And then if I make a clinical judgment, then I may have to say to Elizabeth, well, you have a right to commit suicide, maybe for some reasons of conscience or reasons of law or reasons of policy or whatever. I can't help you. Therefore, what I can do is wish you well and make sure you know all the options and the alternatives before you commit suicide.
And the unfortunate thing in the present state of affairs is that conversation is often engaged in double speak. It's like, well, here's this prescription. Now, I want to make sure you don't take 7 of these pills at once because that would really kill you. So be sure you stay under 7. And it's all done that way. Which I think is one of the motives driving a lot of the people who are behind these initiatives. And we, in fact, in Oregon have an initiative now being challenged in the court for its title, a technical reason, that would put before the voters a bill authorizing in a very restricted range of cases, physician prescribing, no lethal injections, but physician prescribing. And the people putting that together have gone to great care to build into it. The longest part of the document are the safeguards part of the document. All kinds of steps and hurdles that someone requesting this would have to get over. But it at least has the advantage of freeing someone like Howard to talk directly, openly, freely, and publicly about this.
Quick note, very simply, that a lot of relationships are not long-term like this. Of healthcare reform, people bouncing around from one provider to the next. There is no assurance of people really knowing each other in the physician-patient relationship.
I feel Clinton's got enough trouble. We won't tell him today. He's also got to provide for suicide discussions. Let's take a break. If you think Elizabeth and Larry have gotten into trouble so far, wait till you'll see the next one. We'll be back in 10 minutes, exactly.